indeed a great pleasure to welcome you all this evening for this important discussion on uncontrolled hypertension. We have the eminent faculties today, and it's a great honor we at IPCA to have them for this webinar. A great honor to have this topic by this eminent faculties today. Reason is this month, the World Hypertension League has postponed the World Hypertension Day, which normally falls on the month of May, or 17th of May, to October 17th. And beginning of the month, we have a topic and a discussion on uncontrolled hypertension. So with this, it's a great honor to introduce the moderator for today. We have Dr. H.K. Chopra, sir, who's a chief consultant cardiologist at Murchand Medicity Hospital, New Delhi. Dr. Chopra was the national president of the Cardiology Society of India in 2015. Sir was also the national president of the Indian Academy of Echocardiography in 2017. Dr. Chopra, sir, is also the country head of American Heart Association 2015 to 2019. And sir has been a chief editor of various textbooks in the field of cardiology. And every year, yes, he's been giving immense contribution in the form of textbooks to the field of cardiology and into the field of academics. He was also the president of the World Wellness Foundation, president of the World Heart Academy, president of the World Nutrition Academy. And sir was bestowed as the icon of the century in clinical cardiology and echocardiography by Bharat Ratna, former president of India, Dr. APJ Abdul Kalam. Sir has organized more than 2,200 workshops in public health education in the field of cardiology. He has more than 690 publications in various national and international journals of cardiology. He's been a national chief advisor for Tata Sky FAML channel, the only channel in the country which is dedicated for health. He was also bestowed as the icon of the century in the clinical cardiology by the Minister of Health and Family Welfare, Minister of Science and Technology, and Minister of Earth Sciences by the Government of India in the year 2019. It's a great honor to have, has been always been a source of inspiration for us. And it's a honor to hand over the session to him, to Dr. Chopra, sir, to introduce the speakers for the day. So over to you, sir.
Thank you very much, Johnny. Ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here this evening on the occasion of a very prestigious webinar organized by IPCA Laboratories on a very important subject, which I really love from my heart. That is hypertension, a global tsunami. I welcome you all on this occasion. As you all know, that India is the world capital of hypertension. The prevalence in India is almost about 35% in urban population. If you go to rural population, the prevalence is almost about 20 to 22%. But as the age advances, the prevalence becomes more. At the age of 50, it is 50%. At the age of 60, it is 60%. At the age of 70, it is 70%. At the age of 80, it is 85 to 95%. So only few are spared as a normotensive after the age of 80. Now, a very important information I had yesterday, and that is 55% of individuals are unaware that they have hypertension. And 55% are uncontrolled. And 55% of uncontrolled hypertension have STEMI, which I'm sure Dr. Praveen Chandra is going to cover. They have ACS, they have stroke, they have CKD, and they have heart failure. And 30% of patients have PAD or renal artery stenosis or carotid artery disease or aortic involvement. Uncontrolled hypertension, ladies and gentlemen, is a real challenge for us. It's a real disaster. It's a real tsunami, and it's a real hidden terrorist for us. Today only, I'd seen a patient who had dissection of the left carotid artery. Very painful, cause uncontrolled hypertension. So I think it's a very, very important tool It may give rise to a heart attack, brain attack, leg attack, abdominal attack, an eye attack, and whatnot. It is also responsible for vulnerable hemodynamics, vulnerable plaque, vulnerable vessels, and vulnerable hematology. It's really painful. In India, we are all the victims of uncontrolled hypertension only because of lack of awareness. What's the theme today? The theme of this webinar is control uncontrolled hypertension. We have very eminent faculty. It's not easy to find a faculty like this. Dr. Praveen Chandra, Dr. Viveka Kumar, and Dr. A.K. Pancholia. What is the agenda today? The agenda is to have a discussion on the most important topics. The first is uncontrolled hypertension to STEMI, a continuum. Dr. Praveen Chandra is going to speak on this. Power and promise of beta blockers, Dr. Viveka Kumar, and uncontrolled hypertension in comorbidities. What is the role of fixed dose combination? And Dr. Pancholia is going to talk that this is the only solution. Now to introduce our speakers, it's not easy. It's very difficult and Herculean task. Praveen is my very good friend. I know him almost for the last 35 years. When he started his career in Escorts, Apollo, Max, and then Medanta, and now he's also with us in Mulchan Hospital. I'm very happy. He is a very important, a very dynamic man. Padma Shri, Dr. Praveen Chandra, Chairman of Interventional Cardiology, Medanta Medcity, Gurgaon. He's also with us as Chairman of Interventional Cardiology in Mulchan Medanta Heart Institute. He is a recognized leader in the interventions. All my complex cases, whether the patient had angioplasty, they need a atherectomy or rotablator, I refer to either Ashok Seth or Praveen Chandra or Viveka Kumar. They are the three people and they are all with us in various forums. Praveen Chandra has been Padma Shri since 1916 and he served as the director of the cath lab and acute MI at Max Healthcare, consultant cardiologist at the Scott Heart Institute, and he is a fellow of various societies in India as well as international societies, and he received various awards. And I'm very happy to say that he is one of the luminary in the field of cardiology, very well accomplished and known to everyone. I feel really very proud that we have our faculty like Praveen Chandra, Dr. Viveka Kumar, and Dr. Pancholia with us. And he was awarded a prestigious recognition award of success and achievement in the field of angioplasty in India in 1998. Our second speaker is Dr. Viveka Kumar. He's also my very, very good friend, Principal Director and Chief of the Cath Lab, Max Healthcare, Cardiac Sciences, Max Super Specialty Hospital. He has been with us on various occasions. He's been a fellowship in TAVI and structural heart fellowship in USA and Europe and Denmark. And he has various fellowships, both national and international. Expert in all devices. He's also an EP guy as well as an intervention guy. I've done large volumes of complex angioplasties and valvular interventions. As I told you, we three are the face here in India. Ashok Seth, Praveen Chandra, and Viveka Kumar. They are the people we feel very proud from Delhi. They represent whole India and the globe. We are very proud of them. Areas of interest is TAVI, structural heart disease, interventional cardiology, electrophysiology, and devices. Recipient of various awards from DMA, as well as from various awards from various cardiology organizations, and is a speaker and faculty on various national organizations. We have with us Dr. A.K. Pancholia, very good friend. In fact, we studied together in Indore, and I feel very proud when I see him. The way he has grown in the field of academics and cardiology globally. I feel very honored and very humbled to have his contribution in cardiology. He organized first CSI Heart Failure Conference. I'm sure Praveen and Viveka were there. Recipient of BC Roy Award and Chirk Award by MP IMA. And he has also been the Associate Editor of Indian Heart Journal, CSI. And he's also currently convener of Rheumatic Heart Disease Council of CSI. And recently he had a webinar, a very prestigious webinar, and he has submitted a white paper on rheumatic heart disease in India, which is going to be published very soon in Indian Heart Journal. He has been regularly contributing chapters in the various books I had come across. Many books we published in last 10 years or so. He has always been with me, and I feel very humbled and very honored. Ladies and gentlemen, these three speakers are giants in cardiology, and I feel very humbled that they are all with us. With these few words, I'll hand over the mic and request our opening batsman, Dr. Praveen Chandra, to give his presentation on a very, very important subject, uncontrolled hypertension to STEMI a continuum. Dr. Praveen Chandra, sir.
Thank you, Dr. Chopra. And we all know that you have been the leading light of cardiology in India. And why I am saying so is because when I came here for the first time in Delhi, that was the year 1992. Okay, and at that time, the force, because streptokinase was very popular at that time, and I also attended one conference there. I think it was in Mulchan itself or somewhere outside in Ashoka, I don't know, but that was like a huge affair, and I was like sitting and watching what is happening. So Dr. H.K. Chopra is working from that time, so he is now a legend. I must say, walking legend. So very well, Dr. Chopra, congratulations to you. And you are still looking the same kind of Dr. Chopra as I saw in 1992. And Dr. Pancholia also I've been seeing for the last so many years. And he's also fit and fine. And you may be glad to know that he's also a legend in cardiology. And Vivek and myself are newcomers. So we will be here to talk about these things. And he and I were working in Max for some time, and he has now become a legend. So that is good to have some new legends and some old legends. Yeah. So now I'm going to present to you the topic which you already mentioned about hypertension. And hypertension is a very, very important thing, as we realize over the years that it has its own issues. And the occurrence of ST elevation MI is also, we have been seeing, as I already mentioned, that that's where we started, and we are still there at that stage, that we have not been able to decrease the incidence of STMI. We have been able to treat STMI, but now today Dr. Chopra and Dr. Pancholia, what they are saying is that we have not been able to succeed in bringing the incidence of ST elevation MI down, and that one of the big factors is hypertension. And hypertension, and that is why they have labeled this topic as uncontrolled hypertension to STEMI a continuum. Means this cycle or this axis or this nexus between hypertension and ST elevation MI has to be broken. And how do we break that, and what is the current situation? I'm just going to share with you in the next 10-15 minutes or so. Excuse me. Yes. Yeah. So hypertension has been a worldwide problem. It is not only for India, but earlier we thought that it is not so common for Indians, but now we know that it is a problem which plagues India in a very big way, and is one of the leading causes of mortality in India and worldwide. A lot of complications are happening. And if you look at the prevalence and the risk, Dr. Chopra already alluded to that it is about more than 50% patients, despite having treatment, are uncontrolled. And the biggest problem is that it is happening everywhere. Earlier we thought that it doesn't exist in the villages or in the rural areas. But here we see every 10th person in the rural areas is also affected by hypertension, and every 5th person in India from the cities And I must say in Delhi, it must be at least every third person. So that's the real problem. And the real problem then the next is that it starts affecting the target organs, which we do not come to know unless they are already affected. So the challenge is how to protect these delicate target organs like the brain, the heart, the eyes, the kidneys, and the peripheral arteries. All these are affected on a long-term continuous basis. And if we don't control this, we are going to have problem of CAD, stroke, renal failure, all those things are going to happen. And this is already published, as you can see here in this paper from Circulation, that there's so much of association which is already there. And hypertension is a well-known definitive risk factor for development of atherosclerosis in the body everywhere, and sometimes even leading to acute coronary syndromes and acute MI, which is the severest manifestation of atherosclerosis in the human body. So in NSTMI also, hypertension is an independent factor for major short and long-term cardiac adverse outcomes. So you can imagine that hypertension, if it is there, it needs to be controlled. And here you see that so many registries, so many data, and this is starting from the thrombolytic therapy times, that 40% patients who were in the GUSTO trial or the GC trial were having hypertension, which means if these patients were somehow better controlled and better treated, maybe the ST elevation MI would have been avoided. So the main purpose today's talk is that how to break this point from which the hypertension leads to ST elevation MI. That has to be stopped. Now these are the the studies which have been done for showing the prevalence, and as already you're seeing that prevalence is more than 50% in ST elevation MI. So these patients who are having ST elevation MI, nearly half of them have high blood pressure, and also the short and long-term prognosis has been found to be affected in these various studies, showing that if hypertension was associated with impaired post-procedural TIMI flows also, which means the blood flow in the arteries will not improve if patient has hypertension, and despite the fact that he is undergoing angioplasty or thrombolytic therapy. Now, the patients who are likely to have this combination are those who are elderly patients, female patients, then non-white ethnicity, which means we are affected. So I always say that we are always affected from all sides. Whether it is a social scenario, we get floods, we get tsunami, we get everything. And now from the health side, we have so much diabetes, we have so much corona, we have so much hypertension, we have so much disease happening in such an early age in India. So we are really genetically quite predisposed to all these things, and that is why it is leading to a lot of comorbidities and leading to renal failure, acute MI, etc. So what is the mechanism? Why is it happening? So there are certain mechanisms which have been proposed, and these mechanisms basically underscore two key factors, and that is insulin resistance, sympathetic overactivity, and increased vasoactive substances like angiotensin II, leading to accelerated atherosclerosis, contributing to the progression of myocardial infarction. So the pathophysiological factors, as I already discussed, that starting from the genetic risk which we have, and then going on to having all these risk factors of insulin resistance, hypertension, sympathetic overactivity, all leading to spasm, plaque rupture, atherosclerosis, acute MI, and leading to severe increased incidence of mortality.
Please make your slides full screen, and slide is stuck as.
We are not able to see your slides, Praveen.
Acha, you are not able to see my slides?
Only
up
one
till
slide.
Now? Up till now?
Only one slide we are seeing.
Oh my God! So why did you?
Your slides are not moving, sir. Your slides are not moving.
अभी तो मैं 8-10 slide move कर गया. Anyway, let me just see what is happening. Why they are not moving? Okay.
First make it full screen.
अभी कर रहा हूँ.
Full screen and then go ahead.
Yeah.
And it is showing protected view, so I think you have to enable.
Oh, अच्छा. Okay. So now I will let me see.
Yeah, not okay.
Not now?
Now
Yeah,
it's
this
okay.
is fine. This is fine now. We
So
can
are you
see
seeing
it.
this pathophysiological factors that link hypertension?
Yes,
Yeah,
yes, very
yeah,
clearly.
it's
Acute
okay.
coronary syndromes?
Yeah, yeah, it's fine.
Okay, okay, okay. So now let me just change again. Is it okay? Is it changing now?
Yeah, changing.
Complication of hypertension with STEMI.
Yeah, yeah.
Yeah, okay, fine. Sorry. So I just didn't know that the slides are not moving, because for me it was moving over here. So anyway, now the physiological factors, if you look at, which link hypertension with acute coronary syndromes, that was about atherosclerosis and MI and ACS. Why does it happen? As I already said, leading to plaque rupture, increased platelet reactivity, thrombosis, and of course spasm of the arteries. And all this is related to baseline hypertension, which appears to be a very non-malignant kind of thing. And everybody says that it is there for a long time, don't worry about it. But that's really hurting our heart, our patients with such a serious problem. So the complication of hypertension with STEMI, the clinical course of STEMI is affected, and because these many patients have renal failure, they have a lot of glucose imbalance and all those things. So in these patients, they also have associated renal disease. And if you can see here, those patients who have hypertension in STEMI compared to those patients who do not have hypertension in STEMI, if you look at the slide, if you can see the slide, is the slide visible? Dr. Chopra, is the slide visible?
Yeah, it is visible.
Okay, okay, fine. So if you look at this, there is a significant difference between renal disease and hypertension and STEMI. So that's a very bad axis, I must say, where everything is getting affected. And then the outcomes become very bad in these kind of patients. Because if you do intervention in these patients, the contrast nephropathy will be higher. If you do, their patients develop, hypotension, shock, the renal kidney gets even more affected. So all these problems, just compound on each other. And these are the various, data which is available, that how does it complicate the hypertension, complicating ST elevation MI in these patients. And then the outcomes are also affected, increasing the overall mortality. And that is one of the problems seen in various registries, including the shock trial. So this is why it is very important to control hypertension. The risk of anemia in STEMI with hypertension again has been associated with the, in these patients who have anemia, new anemia, they have hypertension in about half of them, and these patients are presenting to us with ST elevation MI. Diabetes again is a very bad axis, as you can see here again. Diabetes, hypertension, and MI, worst combination. And although it looks simple, because we have been kind of seeing this in 40% patients, they have diabetes, 50% patients have hypertension, still we are not concentrating to kill this axis or to cut it off, so that we have decreased incidence of complications and heart failure in these patients. So how do we manage, what to do in these kind of situations? So as you can see here, the blood pressure goals which have been recommended, and these are the blood pressure goals in various kind of patients, in elderly patients, in acute coronary syndromes, in heart failure, post-MI. So that is when the disease has already happened. But when the disease has not happened, of course, those guidelines, those are available, that what should be the target and when should we start acting. And what are the kind of antihypertensive drug recommendations? You can see here that in patients with these occurrences like stable angina, ACS, and heart failure, the ACE inhibitors or ARB, diuretics, and beta blockers are one of the mainstays of therapy, because this is guideline directed medical therapy. And then of course, if the patient requires calcium channel blockers for heart rate control or BP control, we can add. Nitrates again can be added. Aldosterone again more towards patients of heart failure. This can be done, but certainly the up three drugs are very, very important, and they have to be given to these patients. In acute coronary syndrome, so now there is a differentiation, as you can see here. In ACS, what happens? ACE inhibitors or ARB, diuretics, beta blockers, all these can be given, and this is kind of drug of choice. And the number two are the non-drug of choice, but they are add-on drugs. You can add it whenever required. So this is what is the choice as how you can go one by one in these patients. So now you can see that in a patient with stable angina, ACS, and heart failure, these three drugs are the drugs of choice and should be given in these patients. So what should be the kind of guideline target? So to target systolic blood pressure to less than 130 if tolerated, but not less than 120 in patients who have CAD, and in this is like class 1 indication. In elderly patients more than 65, the targets can go up a little bit, and the diastolic should be less than 80 but not less than 70. So that is the guidelines from the ESC ESH 2018 hypertension guidelines. And in hypertensive patients with a history of MI, beta blockers and RAS inhibitors are recommended, as I already showed you, as part of the treatment. So you have to give both these agents and whatever maximal dose the patient is tolerating. And in patients with symptomatic angina, beta blockers or calcium channel blockers are recommended, again as class 1 indication. So that is something which is kind of the way to do in these patients, and these are very straightforward now, very well established guidelines which are available from the ACC/AHA 2017 guidelines. This is again class 1 indication in SIHD, which is stable angina, hypertension, making BP less than 130 by 80. And in adults, we can, with this kind of disease, we can add the drugs, beta blockers and the ARB or ACE inhibitors. Now, patients who are having persistent uncontrolled hypertension, one can add dihydropyridine calcium blockers and two beta blockers. That is a good combination. We can do this. And patients who have had acute MI or coronary syndrome, they should be continued for beyond 3 years as long-term therapy for hypertension. So it can be continued for long time. And this is class 2 recommendation. And if required, calcium channel blockers may also be considered to control hypertension along with beta blockers in patients with normal ejection fraction who had MI more than 3 years back. So that is the addition of therapies which you can do. So this is the algorithm which you can use for adding calcium blockers and diuretics in these patients who are already on beta blockers, ACE inhibitors, or ARBs. Now, this is the recommendation. ACS patients with hypertension represent a subset of very high-risk individuals, and generally they are older. Generally, they have high comorbidities, as you already saw in these slides, that they start attracting a lot of disease in the kidneys and peripheral arteries. So they should be carefully monitored to achieve adequate perfusion pressure also. And the goal is to prevent renal failure due to hypoperfusion. So that is something which one has to keep in mind, that you don't have to bring it down too low so that they start getting renal hypoperfusion. Then in patients who have normal ejection fraction, we have to look for these days for diastolic functions, and that is done by echocardiography to diagnose HFpEF, which is heart failure with preserved ejection fraction, and also in these patients hypertensive crisis to be avoided. It can lead to a development of acute heart failure. So all these things are very, very important. Comorbidities have to be searched because many of these patients will have comorbidities like insulin resistance, glucose imbalance, and increased HbA1c levels. Anemia is also one very important comorbidities. A lot of studies have really concentrated on controlling anemia in these patients and exclude the coexistence of renal failure. So many patients who do not get controlled and they have CAD, one should also start thinking of renal artery stenosis. And there was some time about 10 years back when every angiography, people used to do a flyby angiography, flyby renal angiography. But now, since the trials, the coral trials, etc., which were done for renal artery stenting or stenosis, did not show positive outcomes. So now it is out of fashion these days to do a renal angiography. But certainly in uncontrolled hypertension, it should be done. And a strict follow-up should be done in ACS patients with hypertension, close adherence of drug administration, and many times, many drugs will be required. So one should not kind of refrain from using multiple drugs in these patients to control hypertension as much as possible. So with this, I will stop here, and maybe if there are any quick comments, I will be very happy to answer. Dr. Chopra, your mic is muted.
Thank you very much, Dr. Praveen Chandra. It was the most beautiful and the lucid presentation. I think we can take the questions in the end because most of them will be overlapping. It was a brilliant talk. I think we really want to congratulate you. A fantastic talk. The next speaker we have is Dr. Viveka Kumar. He's talking on power and promise of beta blockers. Should it be used? Should it be condemned? Should it be out of the packet? Should we use in youngsters or only with the old people with comorbidities? Let's see what Viveka has to say. Dr. Viveka Kumar, sir.
Well, so good evening, friends. Let me at the outset thank IPCA for bringing us together on this Hypertension Summit, and special thanks to Dr. Chopra for kind introduction, and big hello to Dr. Pancholia and Dr. Praveen Chandra for being with us this evening. So in this pandemic, we are meeting virtually, but we used to meet quite often physically. So let's hope that we do very soon once the vaccine comes or the corona disease goes into kind of we develop herd immunity or something is being done for that. So if we look at the power and promise of beta blocker in uncontrolled hypertension with comorbidities, one of the comorbidities which Dr. Praveen Chandra did talk quite lucidly was the acute coronary syndrome, where the maximum evidence and most robust power of this agent is there. And if you look at the problem of hypertension, it's a major public health concern, affects 26% of the adults worldwide. So you can imagine how big the health problem is. And 1.6 billion hypertensive patients are estimated to be there by 2025. So you can imagine how much the economy will be drained as far as the healthcare budget is concerned because of the hypertension. And uncontrolled hypertension is a major risk factor for cardiovascular disease, as it has already been discussed that it is present in 69% of the patients with first myocardial infarction. So you can imagine the risk of hypertension translating into acute coronary syndrome and myocardial infarction. And in 77% of the patients with first stroke, so again, it's a huge chunk. In 74% patients with chronic heart failure, 60% patients with ischemic heart disease, and older persons are more likely to have hypertension and isolated systolic hypertension, as at one point in time it was considered to be part of the aging process. So as the age advances, that is quite natural, but the worrisome point is that we are getting more and more young hypertensive patients. And there is a very, very robust data of intervention trial that shows that a small reduction in blood pressure to the tune of 2 millimeters mercury reduction in mean office systolic blood pressure decreases 10% risk in stroke mortality. So that's a very, very hard endpoint, a 10% reduction in stroke mortality and almost 7% plus in risk of ischemic heart disease mortality overall. So that's a very, very important message to me. This is the slide of the day where we can convince our patients and the public at large that, look, if we control the blood pressure, the cardiovascular mortality comes down very significantly. Beta blockers in uncontrolled hypertension has been used as the drug of choice for treatment of complicated hypertension in patients who have got, as I said, the coronary artery disease with, angina, and be it unstable angina, even in acute myocardial infarction. This is the drug to be trusted on. And it is useful, especially in those with history of angina or myocardial infarction. And it is also beneficial in complicated hypertension. This is a very busy slide which looks at the journey of beta blockers. You can see here in 1958, the James Black researched out beta blocker, and then we had propranolol in 62. We had another molecule that is practicolol 1964, but it was launched in 65, but it was withdrawn later on because of the various complications. And you can see in 1988, Sir James Black got Nobel Prize for discovering beta blockers, so such an important molecule. So if you look at the initial journey, it started from non-selective beta blockers to cardioselective, and cardioselective with lipophilicity, so that the side effects are less and less, and it is more targeted effect on the heart. So we have, if we classify the beta blockers, as this has been taken from Journal of Clinical Hypertension 2009 classification. So first generation non-selective beta blockers within olden age used to use propranolol, sotalol, which is more of an anti-arrhythmic, and pindolol and nadolol was there. But if you look at the second generation beta 1 selective, that had atenolol, bisoprolol, which we have been using quite a lot, and esmolol, which is a very short-acting, and the metoprolol. Then the third generation vasodilatory function, which has got additional alpha-blocking activity, causes peripheral vasodilatation, and more prominent of them is carvedilol and labetalol, and beta-1 selectivity, nebivolol and betaxolol is there. So if you look at the organ effects of beta blocker, because of the selectivity, definitely we go with the bisoprolol, ethanol, and metoprolol, which has got more effect on the myocardium, and the other organs like heart rate reduction, decrease in contractility, decrease in AV conduction. These are the effects which the beta blocker has, but simultaneously it can have a problem in patients who have got concomitant airway disease, or even in diabetics for response in hypoglycemic situation. So beta 1 selectivity of various beta blockers we look at, the bisoprolol and metoprolol has strong, the ethanol is milder in that form, and these two molecules have got longer half-life. Carvedilol does not have the selectivity, but nebivolol is highly beta 1, beta 2 selectivity is there. So if you look at the antihypertensive actions of beta blocker, it should be ideally the mean arterial blood pressure should drop, total peripheral resistance should drop, but traditionally the beta blockers increases the peripheral vascular resistance, and cardiac output should be neutral. But if you look at the beta blocker, they do decrease a little bit. Heart rate also gets decreased with this, and obviously the sympathetic nervous system excitation is decreased, and RAS system activation also gets decreased. So there is a systolic and diastolic blood pressure reduction with metoprolol. So effect of metoprolol on erect and supine blood pressure, you can clearly see that the pre-treatment, that is black bar, and the after treatment, which is the white bar, clearly shows that when you look at the systolic or diastolic blood pressure, both go down with metoprolol. And the mortality reduction in diabetic hypertensive patients, and that was a 10-year data from UKPDS trial, and that clearly showed in this large trial that there was significant reduction, above on the ACE inhibitor. There were 23% reduction from any cause, death from any cause was with the beta blocker. The beta blockers in comorbidities associated with uncontrolled hypertension, you can see utility of beta blocker in comorbidities associated with uncontrolled hypertension. The patients who have got uncontrolled hypertension, it protects from arrhythmias, post-myocardial infarctions, arrhythmias, congestive heart failure, angina. So in patients who have these comorbidities, they get protected with beta blocker. In ischemic heart disease, this is the drug of choice. You can clearly see that the incidence of atrial fibrillation, diastolic heart failure, systolic heart failure, risk of stroke, all these endpoints, are achieved. Not only that, hypertension is also well controlled. And one of the reasons why in acute setting, it can be given in ACS and acute myocardial infarction, that also, decreases the sympathetic overactivity and thereby decreases the overall adverse events. So if you see the beta blocker in ischemic heart disease, how does it help? What it does is that it decreases the heart rate by working at sinoatrial node, decrease the oxygen demand because the cardiac stress becomes lesser, myocardium oxygen demand goes down, the myocardial contractility also goes down, and decrease the blood pressure. So afterload reduction is there, and the myocardial oxygen demand also goes down significantly. So no wonder that all the trials shows that reduced mortality with beta blocker in stable ischemic heart disease, and beta blocker is the first line therapy in the treatment of hypertensive patients who have got concomitant ischemic heart disease. And this data clearly shows that up to 1 year post-myocardial infarction, if you give beta blocker, the odds ratio clearly shows that the mortality is significantly lower. And then even more than 3 years of patients who had a myocardial infarction, there again, the mortality rate is significantly lower. In post-myocardial infarction, it reduces the oxygen demand, reduces the heart rate and blood pressure, contractility goes down, decreases the automaticity, and also the infarct size reduction. So when the thrombolysis or anything is not there, acute primary angioplasty is not available, give beta blockers so that the infarct size goes down. Again, the data shows that reduced mortality with beta blockers in MI is there, and this data was from 2 years data, which shows a lower mortality was observed after 3 months in patient randomized to metoprolol. You can clearly see that the incidence of death with large infarction was almost more than half with metoprolol, from 32% to almost 12.5%. Sudden death is a significant reduction with beta blockers. We can almost 1/3 sudden death is there in beta blocker metoprolol arm, and non-fatal infarction is again almost half in patients who are on metoprolol compared to those who are on placebo. So beta blocker for long-term in chronic post-myocardial infarction patients also, if you see no matter which beta blocker you choose, more or less it has got a protective effect, except those one who have got intrinsic sympathetic activity is also there. So approach to use of beta blocker in chronic MI period, again, is a very busy slide, but bottom line is that we need to avoid the contraindication like peripheral vascular disease, COPD and all. Otherwise, we need to have a valid reason why we haven't used this in this setting of post-myocardial infarction period, because it not only improves the ejection fraction, not only decreases the sudden cardiac death, but overall systolic heart failure also gets benefited with this. So in heart failure, as I said, of late, there was a time when beta blocker was contraindicated in heart failure with reduced ejection fraction, but not now. It is a class 1 recommendation to use this molecule. So in these patients, hypertension accounts for 50 to 60% cases of heart failure with reduced ejection fraction. And in elderly, it accounts for almost 70% of heart failure. And in patients with hypertension, the risk of heart failure is increased by 2-fold in men and almost 3-fold in women. So increased sympathetic overactivity in heart failure is there. And that is why the beta blockers are having such a good response, because it decreases the adrenergic overdrive and causes down regulation of beta receptors so that the heart does not have to flog harder. So progression from hypertension to heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. So this is a continuum where the uncontrolled hypertension would cause concentric hypertrophy, and that would lead to diastolic heart failure. So this is a large chunk of population who has got diastolic heart failure. And remember, it's not an innocuous disease. It can also have very high mortality rate. And then as the patient's heart goes into hypertrophy dilatory phase, the patient slips into gradually heart failure with reduced ejection fraction with its serious consequences. In these situations, the beta blockers are helpful for neurohumoral action, hemodynamic effect, and restoration of beta receptor responsiveness is there. And selective beta 1 blocker and reduced sympathetic activity in heart failure leads to cardiac remodeling and also slows down the progression of heart failure in these patients. So reduced mortality in heart failure with HFrEF with metoprolol, if you look at the MERIT-HF trial, there was a very robust reduction, almost 40% less mortality, cumulative mortality in patients who were followed up for almost 2 years in this trial. Those who were on metoprolol in MERIT-HF trial did show significant benefit. Other cardiac indications are that it's a classical indication for hypertrophic cardiomyopathy, which is the first choice in dissected aortic aneurysm. It decreases the wall stress on the aorta, so it should be given in acute aortic syndromes as well. And it is has got a very well established anti-arrhythmic action as well, and that is why it decreases the mortality, especially the certain beta blockers like sotalol and all. It's purely classified as an anti-arrhythmic agent. So if you look at the guideline, we would say that the beta blockers for the management of hypertension with associated ischemic heart disease 2017 ACC/AHA hypertension guideline also suggests that we can add beta blockers in these subset of patients, and still the patient has got angina, then we can use the CCB also in to alleviate the anginal symptoms. And again, if you look at the recommendation, class 1 recommendation that in adults with ischemic heart disease with angina and persistent uncontrolled hypertension, the addition of dihydropyridine CCB to guideline directed medical therapy with beta blocker is recommended. So first line is always a beta blocker in these settings. Again, if you look at the ESC guideline 2017 STEMI guideline, early administration of IV beta blocker at the time of presentation followed by oral beta blocker should be considered in hemodynamically stable patients undergoing primary PCI. And there also the recommendations are, class 1 and level of evidence is A. So meaning thereby that in these acute settings also the uses of beta blocker is going to be beneficial. And in long-term management of STEMI, non-STEMI also the guidelines supports quite heavily that the beta blocker should be used in these settings, whether the heart failure with acute coronary syndrome with reduced ejection fraction is there, or even in preserved ejection fraction. And the recommendations are class 1 and class 2A. So in heart failure, as I said, the selective beta blockers such as metoprolol, bisoprolol, and carbidopa may be used in patients with congestive heart failure established with ACE inhibitors and diuretics who are on other guideline mediated therapy. They should be put on beta blockers to have a better outcome in these patients. So utility of beta blocker in complicated hypertension, if you look at the ESC 2018 hypertensive guideline, there also the patients have the, we need to, apart from ACE inhibitor, ARBs and CCBs and diuretics, the beta blocker has got a strong indications to be used in patients who have got, here the beta blocker should be considered at any treatment step. It can be first step as well. If the patient has got concomitant heart failure, angina, post-myocardial infarction, atrial fibrillation, and younger the patient, the more benefit of this, because in younger patients, you need to control the sympathetic overactivity to control the blood pressure. So to sum up, I would say that the use of beta blocker in cardiovascular disease, it is there in heart failure, post-myocardial infarction, patients who have got post-MI arrhythmias, and again, in patients who have got ACS, acute MI, hypertension per se, and patients who have got hypertension standalone indication, especially in younger population. To conclude, I would say hypertension is a growing burden worldwide, and uncontrolled hypertension is a major determinant of various cardiovascular conditions. Uncontrolled hypertension is associated with cardiovascular conditions like ischemic heart disease, myocardial infarction, heart failure, arrhythmia, and etc. Beta blocker, owing to its sympathetoinhibitory action, are useful in complicated hypertension with ischemic heart disease, post-myocardial infarction, and heart failure. Evidence-based beta blocker therapy with especially the data is more robust with bisoprolol, metoprolol, and carbidopa is a mainstay of treatment in all symptomatic patients with hypertension and cardiac comorbidities together. Thank you very much for your kind attention. And if there is any question, we will answer at the end. So over to Dr. Chopra again.
Thank you very much, Dr. Viveka Kumar. I think it was very nice and very meaningful presentation. As we discussed earlier, that we'll have the discussion at the end of all the speakers' talk. So with this, we'll go to the next speaker, Dr. A.K. Pancholia, and the topic is going to cover is uncontrolled hypertension with comorbidities. Fixed dose combination pill is the only solution. Dr. Pancholia, sir.
Thank you, sir. It is indeed a great pleasure to be associated with stalwarts in the cardiology, Dr. Chopra, Dr. Praveen Chandra, and Dr. Viveka Kumar. And special thanks to IPCA for organizing this wonderful program. In next 10 to 15 minutes, I shall be speaking on the role of fixed dose combination pill, the only solution in uncontrolled hypertension. As you know, hypertension is the leading cause of cardiovascular morbidity and the leading cause of death by the country income level. Cardiovascular mortality risk doubles with each 20 by 10 millimeter mercury BP increment. Reduced systolic blood pressure is associated with the reduced risk of cardiovascular events, both stroke and ischemic heart disease, and same thing for the reduction in the diastolic blood pressure. And there are several trials are available which clearly show the importance of lowering blood pressure. But despite of all these facts, most people with hypertension globally do not have it under control. Less than 1 in 7 with hypertension worldwide have it under control. Control of hypertension in India, this is the Indian scenario, which clearly showed only 15.4% of the total hypertensive group have blood pressure under control, is the Indian scenario. The hurdles to the blood pressure control are at the level of diagnosis, at the level of for inadequate BP control, the use of monotherapy or some patients, resistant hypertension, non-adherence to the therapy, drug-induced side effects, and drug cost. Monotherapy for the hypertension is inadequate in 40 to 50% of the patients, and monotherapy corrects only one physiological pathway of hypertension, not several many, and therefore multiple medications are required to achieve the BP control in clinical trials. The trials related to hypertension like Accomplish, Alert, and Our trial, diabetic trials like Accord, Invest, IDNT, and renal trial, and kidney-related disease problems, MDRD, and AS trial. All trials clearly showed that more than 2 drugs are required for the control of blood pressure. 1/3 of the hypertensive patients are already treated by 3 or more antihypertensive drugs, and thus combination therapy is a practical necessity. There are several advantages of the combination therapy: increased efficacy of the drugs, shorter time to achieve the BP goal, effective BP control, additive action, offset the side effects of each other, fewer pills, and improvement in the compliance. But less number of patients are on combination therapy compared to monotherapy in various countries, not only in India, but other countries also. Combination therapy has additive blood pressure lowering effects, and combination of the complementary therapies may improve the drug efficacy. Meta-analysis of 42 randomized clinical trials performed in approximately 11,000 patients with the arterial hypertension clearly showed that combining drugs from the different classes is approximately 5 times more effective in lowering the blood pressure than doubling the dose of a single drug. Initial combination therapy versus monotherapy increases the chances of BP control over 1 year. And cardiovascular risk associated with initial monotherapy is more versus combination therapy, so far cardiovascular, coronary, and cerebrovascular accidents are concerned. The reduction in cardiovascular events seen with the initial combination therapy, with reduction in any cardiovascular events, reduction in ischemic heart disease, reduction in cerebrovascular disease, heart failure as well as atrial fibrillation, better with the initial combination therapy compared to monotherapy. Combination therapy is moreover is well tolerated. Combination therapy does not double the number of adverse events, and the use of combination versus monotherapy reduces the risk of treatment discontinuation by 73%. There is reduction in the risk of hospitalization also with the increased level of compliance because of combination therapy. And these are the possible combination classes of antihypertensive drugs by European Society of Cardiology and European Society of Hypertension, where the preferred combinations are AC inhibitors, diuretic, ARB plus diuretic, AC inhibitor plus CCB, and ARB with CCB. These are the preferred combinations. What the guideline says, NICE guideline in 2011 clearly showed that in step 2, we have to give combination therapy of RAS blockers in combination with CCB or the diuretic therapy. And this is also same endorsed by the British Hypertension Society, A plus C combination, or if not controlled, then triple combination of A, C, and D. The Indian guidelines also recommended the same, the AC or ARB in combination with CCB or thiazide diuretics. But there are disadvantages of the combination therapy regimes. Free drug combination therapy regimes are more complex than those for the monotherapy. Treatment with separate drugs increases the pill burden, reduction in the convenience for the patient. This complexity contributes to suboptimal adherence and persistence with the therapy. And so what the solution and what the answer for this? And here is the answer, that is single pill combination or fixed dose combination therapy. Single pill combination are more efficient than the free combinations. Higher BP control rates are achieved with the single pill combinations. More patients, they achieve the BP control within 12 months of the single pill combination. And it is also observed in the observational studies and the randomized control trials. Both showed better effects with the combination therapy, a single pill combination. Higher rate of hypertension control in the grade 2 to grade 3 hypertension, less in the grade 1 hypertension. There is improved adherence with the fixed dose combination therapy compared with the free combination therapy. And the meta-analysis of 9 trials clearly showed the benefit of a single pill combination compared to the free drug combination. Increased compliance gap between the fixed dose combination and the dual agent regardless of the concomitant medications. And there is a persistence with the antihypertensive therapy regime with a single pill combination compared to the free drug combination. So what is the impact of fixed dose combination on cardiovascular outcome? And you can clearly see here there is a substantial reduction in the CHD, stroke, heart failure, and death with the single pill combination or the fixed dose combination compared to the free drug combination. And overall, if you summarize, the convenience is much more with the single pill combination. Adherence is also much more. Efficacy is much more. Tolerability is much more. But the flexibility is the question mark, which is more with the monotherapy and free combination rather than single pill combination. And this is the STITCH trial, which is comparing the guideline care algorithm compared with the STITCH care algorithm. A STITCH care algorithm is a fixed dose combination therapy, and it clearly showed a better control of blood pressure with a fixed dose combination, which has endorsed in the STITCH program compared to the usual care. And this is the Indian experience of the ESCAPE study from India. The efficacy of the efficacy and safety of the bisoprolol plus amlodipine, a fixed dose combination, and it clearly showed a change in the systolic blood pressure, persistent and significant fall in systolic blood pressure by 21.8% versus the baseline with the fixed dose combination. And we have seen in last couple of years a rising growth of fixed dose combination. It was 10.7% in 2005 and going to 12.4% in 2008 and is still on the rise. Now the question comes, is 2-drug combination enough? 60% of the hypertensive patients are uncontrolled by the 2-drug antihypertensive therapy, and thus there is a need for a triple drug fixed dose combination in hypertension. And this is a recent lecture by G. Mencia, the father of hypertension in the world, from Italy, and he delivered a lecture on the use of triple combination in hypertension management from guidelines to the clinical practice. And what he says, the core drug treatment strategies for hypertension is step 1, you start with the dual fixed dose combination. If not controlled, then go for the triple combination. And even if it is not controlled, then triple combination along with the other drugs to be initiated. Triple drug therapy have a better BP reduction, and triple antihypertensive agents are needed to achieve the BP control in approximately 25% of the patients. Triple drug therapy goes further in terms of BP lowering efficacy and of course the target organ protection. Reduce incidence of the disease also by number of antihypertensive drugs, but the stroke reduction is only 29% with a single drug, only 49% with the 2 drugs, but around 63% by the 3 drugs. Similarly, the CHF reduction by 19% with 1 drug, 34% with 2 drugs, and 46% with the 3-drug combination. Relative risk of various outcomes in BP lowering randomized controlled trials of the triple therapy versus any potentially less treatment, and you can clearly see in this forest plot the favorable effects in terms of stroke, CHD, heart failure, stroke, and CHD with the triple drug combination. And this is the recent paper from Berlin, the effect of single pill triple fixed dose combination therapy combined with a single component therapeutic drug monitoring in treatment with resistant hypertension. And you can clearly see in 18 weeks, there is substantial reduction in the systolic and diastolic blood pressure with the triple fixed dose combination. And this is another paper, fixed dose triple combination of antihypertensive drugs, which clearly showed a reduction in the 24 hours of BP values, reduction in the diurnal BP values, and reduction in the nocturnal BP values. And single pill combination are recommended by the guidelines. This is the Asia Pacific consensus document. We had a meeting in Vietnam 2013, and we come out with a statement here. The report summarizes the key recommendation from the group including recommended antihypertensive combination for the specific patient populations. These strategies generally entail initiating therapy with a free drug combination, starting with the lowest available doses, followed by the treatment with single pill combination once the BP target has been achieved. And this is endorsed by the ESC guideline 2018. Initial therapy is a single pill, a combination of AC or ARB with CCB. If not controlled, it is step 2, then the combination of the AC, ARB plus CCB plus diuretics. The triple fixed dose combination has been recommended by the ESC guideline. And this is the recent International Society of Hypertension 2020 guidelines. We clearly endorse the initial therapy should be a dual low dose combination. If not controlled, then go for the triple combination. Now, why guidelines they prefer the RAS blocker, CCB and diuretic is the triple combination. Why they have endorsed that, and the reason behind that, there's a complementary mechanism of action, large BP reductions, favorable tolerability profile, protection against the subclinical organ damage of the prognostic significance, and no ad hoc randomized control trials, but the large use in successful outcome, the randomized control trial or trials, the post hoc analysis or meta-analysis. Other triple combinations in hypertension with compelling indications. In diabetic patients, the same thing, RAS blockers with the CCB. If not controlled, then RAS blocker CCB with the diuretics. And in patients with coronary artery disease, we already discussed. Here instead of diuretic, they have endorsed beta blockers, the RAS blockers plus beta blockers or CCB combination. And patient with the chronic kidney disease, again RAS blockers with CCB. If not controlled, then RAS blocker CCB with the diuretic. It is also endorsed by the Japanese Society of Hypertension and also been endorsed by the Korean Society of Hypertension. And this is very latest. The World Health Organization, the Modest List of Essential Medicines, on July 9, 2019, WHO added fixed dose combination antihypertensive medications to the WHO Essential Medicine list. But there are limitations of the fixed dose combinations, less flexibility with the dosing than the free drug combination. One of the drug may be ineffective and ascribing the side effects more difficult. So there are certain limitations also there. So take home, uncontrolled hypertension, the big fixed dose combination pill is the solution. Why? Because the fixed dose combination are more convenient, more compliant with the patients, better effects, less side effects, low cost compared to the separate drug agents and monotherapy. And it is also been endorsed by practically all the guidelines. And I wrote a recent chapter in the manual of hypertension on combination therapy. What is the rationale? Thank you very much.
Thank you very much, Dr. Pancholia. It was a very nice presentation with a more emphasis on fixed dose triple combination, which is the need of the hour. I'm sure there'll be a lot of questions I'm seeing in the chat box. We'll have the questions first. Let me open the chat box here. I think the first question is Dr. Hem Shankar Sharma from Bhogalpur. Best combination for heart failure with preserved ejection fraction and hypertension. Dr. Pancholia. What is the best combination of patient with hypertension with heart failure and preserved ejection fraction?
Look here for the hypertension control, because hypertension is one of the important cause for the heart failure with preserved ejection fraction, and we have to control the blood pressure as a treatment for the HFpEF, because as such for the HFpEF there are no remedies. All the trials have been failed, no better effects. So better is the control of the comorbidity, and the comorbidity is one of the comorbidities, hypertension. So that is to be controlled. And here the initial choice would be RAS blockers in combination with the calcium channel blockers. And if not controlled, then diuretics to be added, because one of the trial showed the importance of the diuretic therapy, particularly in patients with HFpEF patients, for some beneficial effect. So diuretic in combination with the RAS blockers should be the choice in HFpEF patients with hypertension.
The next question from Indore, Dr. Ajit Bhatt. I'm sure you might be knowing him. How to narrow the pulse pressure in elderly patients with a diastolic being 60 or even less? Dr. Pancholia, you want to address this? how to reduce the diastolic or pulse pressure when the diastolic goes down less than 60.
Here we have to concentrate mainly on the systolic blood pressure, and the drugs are there for the systolic blood pressure reduction. So by reducing the systolic blood pressure, we can narrow down the pulse pressure.
Okay. There is one more question from Dr. Ashok Delhi. A role of metoprolol succinate 12.5 milligram as a monotherapy and its role in arrhythmia with stroke along with the hypertension. What do you think? Monotherapy in patient with arrhythmia or stroke with hypertension. Metoprolol succinate 12.5 milligram. Dr. Pancholia?
This is beta blocker related question, Dr. Viveka Kumar.
Okay.
Yeah. Yes, I think that's a very good question. So, if you look at the potency wise, the long acting metoprolol succinate 12.5 milligram would be equivalent to almost 25 milligram of the conventional metoprolol. So I would say that it decreased as I have just enumerated the data, also the stroke risk and also the risk of cardiovascular mortality would go down significantly, especially the arrhythmia. So if somebody is having frequent ventricular ectopics or the patient has got hyperenergic induced supraventricular arrhythmias or ventricular arrhythmias, it will go down significantly, especially in those patients who are having ejection fraction less than 40%. There the benefits of using this will be even better. So I would say that yes, the 12.5 milligram, we should not stop at 12.5 milligram alone. We need to up titrate it and see how much is the maximum possible tolerable dose, because if you look at the trials, the dose which was used was 50 to 100 milligrams, and the highest possible dose is 200 milligrams. So we should up titrate it to get the benefit which has been achieved in different trials. Especially I think if you're talking about MERIT-HF trial, then also we need to up titrate. But I think the answer is yes, the risk of stroke and cardiac arrhythmias will go down significantly even with the monotherapy if we are using it as an antihypertensive agent.
Thank you very much, Dr. Viveka Kumar. I think they're very, very important questions. And Dr. Praveen Chandra, I think very, very authoritatively mentioned that almost 55 to 60% of patients who come to him with STEMI or who undergo PCI, they have a hypertension which is uncontrolled in nature. And if the hypertension is uncontrolled, he said that the morbidity and mortality is very high. It is not by the procedure per se, it is by the risk factor which is associated with the procedure, with the STEMI. I think it's very important. Second thing which was very nicely highlighted by Praveen Chandra was the role of echo. I think it's underestimated. I was addressing Kolkata in one of the echo conference. A lot of clinical and interventional cardiologists were there. And there was a lot of debate. Should we subject our hypertensive patient for echo or not? If you ask my personal opinion and based on the ESC, American Society of Echocardiography, every patient of hypertension should have an echocardiographic evaluation to see so many things, which is mentioned by all the three speakers: heart failure with preserved ejection fraction, LVOT gradient, LV hypertrophy, LV remodeling, LV strain rate, LA strain rate. So many things we can predict. I think echocardiography is a very, very important tool in evaluation of hypertension in setting of STEMI or ACS, very nicely highlighted by Dr. Praveen Chandra. Dr. Viveka Kumar was very categorical, mentioning about the selectivity of the beta blockers. Like he used the word, he classified generation 1, generation 2, and generation 3. In generation 2, he mentioned about bisoprolol and metoprolol. Bisoprolol and metoprolol are the best beta blockers today. Whether we use tartrate, beta blocker, metoprolol, or use succinate, they are very, very good. There's not much of debate, except they find that there is a little minor benefit of tartrate as compared to succinate, but otherwise both of them are really good. Bisoprolol is a drug of choice in resistant hypertension. There is a lot of data in my statement, what I'm saying. And I think he mentioned very nicely the guidelines. The third important point, which has been expressed by our colleague, Dr. Pancholia, very forcefully, taking a whole globe guidelines. He wanted to create a global pressure on us. The fixed dose combination is the need of the hour. And ladies and gentlemen, the message is very clear. Uncontrolled hypertension has to be controlled. And the only way we can control is by massive hypertension campaign. I'm very happy to say today that Dr. Viveka Kumar, Dr. Pancholia are involved with me, and I'm sure now Dr. Praveen Chandra will also be involved on the mission hypertension, which we launched almost 2 years ago. And we had 2 meetings already, and 3rd meeting is just in the process of completion. And we like to involve Praveen Chandra also on the mission of Attack Heart Attack, which also we launched 2 years ago on the television. And again, IPCA is the academic partner for that. I'm very grateful to IPCA that they are doing a very public campaign, public education, along with the CME. The question was fixed dose combination triple dose is very well forcefully, authoritatively highlighted by Dr. Pancholia, because it definitely reduced the pill load, the bill load, and the memory load, the vulnerability load, and the hemodynamic load, and the morbidity and mortality load. It totally unloads us. Fixed dose combination is the only answer. I'm using a lot of patients fixed dose combination, the combination of chlorthalidone along with calcium channel blocker like amlodipine and telmisartan. CT-DAM, lot of my patients are using it. It's enormous benefit. We use various combination, but I think this is really a combination because the compliance is markedly improved, as already suggested by Dr. Pancholia. Adherence is markedly improved, and the success rate and the dose is also less. I think all the points are very well highlighted by Dr. Pancholia. Usefulness of beta blocker is very important. I think in the fixed dose combination, only I think one study which was showing that we can use beta blocker, but beta blocker are widely used in patients with the comorbidity. If there are any more questions or any more comments, Dr. Praveen Chandra, Dr. Viveka Kumar, or Dr. Pancholia, please go ahead before we give a final concluding remark. Dr. Praveen Chandra, please.
Yeah. Thank you, Dr. Chopra. I think, we have really nailed on this subject, which is looking simple, but it is very complex, that the hypertension and STEMI association and hypertension and comorbidities association is still not broken, despite all these medications and despite all these efforts. So your this mission will be a great direction towards that attempt. And we have to look at, and we are looking forward to that time when in the MI databases we start looking at reduction of hypertension from 50% to 20%, and from our interventional cardiology databases we should start looking at hypertension association to less than because it is about 40% everywhere. Yeah. So what have we achieved? Nothing. So we have to really look at this, and we have to work together to find a solution to this huge problem, and then only we'll reduce the incidence of acute MIs and other comorbidities like renal failure, acute non-STMI, and of course stable angina. So with this, I will thank you all of you, and
thank you,
hope to see you soon.
There are some important questions for you on STEMI now. I think they'll come now. One is Dr. Madhav. He's asking Dr. Praveen Chandra specifically, STEMI in the COVID era, whether primary angioplasty is still preferred.
Okay, that's a good question. But now everything, everywhere the policies have evolved that thrombolytic therapy is the drug of choice for acute MI as of today. And in those people where there is a clear evidence that it is COVID negative, then in these patients we can do a primary angioplasty, but otherwise we give thrombolytic therapy. And now the approach of pharmaco-invasive approach is working very well in this kind of situation. So pharmaco-invasive means you do thrombolysis, get a quick NAT test or something like that, and within 3 hours or within the first 24 hours you can do the intervention to these patients with very good results.
One more question to Dr. Praveen Chandra is, after thrombolysis in acute MI, when we will take the patient for CAG and what precautions to be taken for doing any intervention after they are given thrombolysis in patient with MI and hypertension? Dr. Praveen Chandra.
Okay.
Sir.
Yeah. So as I said already, that don't bring the BP down too much and don't leave it too high. It should be in the range of about 130 or so, below 130 and above 120, because perfusion is one of the key factors, and the diastolic also should not go below 70. So these are the quick guidelines for that. And the second is you have to do the angiography as within the first 24 hours after successful thrombolysis. But if the patient is not thrombolized, old MI, then there is no need to do a angiography in every case. You can send them for a ischemia evaluation by thallium or a stress test and then do the angiography. But in high risk patients like large anterior MI, low ejection fraction, arrhythmias, instability, there the angiography has to be done in the first in hospital care and then make a decision as to what you have to do.
Dr. Ish Karpalia from New Delhi. The question is addressed to Dr. Viveka Kumar. Hypertension with sinus tachycardia. In a middle-aged patient, what is the role of beta blockers as an initial management or as an additional management post-echo evaluation? Viveka.
Yes, so I think that's a very good question. So Dr. Katpalia, I think if the patient is having sinus tachycardia at basal state, so it means that the patient's adrenergic drive is higher, and whether it is heart failure or reduced ejection fraction, meaning thereby that on echo, even if the blood ejection fraction is less than 40%, the patient is going to be benefited by beta blocker. So we must add that. And even if the heart failure is ejection fraction is preserved on echocardiography, then also the basal heart rate, which is high, should be controlled, because there is a very strong relation between heart rate and mortality, cardiovascular mortality. So we should try to control the heart rate, and the beta blocker is the best way to. So in both the situation, whether it is reduced ejection fraction, in reduced ejection fraction with higher basal heart rate, the benefits are even more. And in patients who have got preserved ejection fraction and the basal heart rate, if it is high, then also the beta blocker would be the drug of choice. And then we need to look at the how much the blood pressure is, because if you look at the guidelines, we need to try to keep the systolic blood pressure less than 130 and diastolic less than 90. And if we can achieve it with the up titration of beta blocker alone, that's good. Otherwise, as Dr. Pancholia has rightly said, we can straight away go to combination therapy and control the blood pressure.
One more, thank you, Dr. Viveka Kumar. One more question for Dr. Praveen Chandra. And the question is, let's find it here. Question is here. Many COVID positive patients with high troponins and STEMI on ECG have mild CAD or normal coronaries on angiogram. What could be possible mechanism or reason? Dr. Praveen Chandra. Good questions. Very question. A lot of questions. Praveen, you heard the question? The question is by Dr. Naresh. Dr. Praveen? Can you hear me, Dr. Praveen Chandra? No, I think you can't hear. Okay, I'll request Viveka to respond to this question.
Yes, I think, so I've heard the question. So let me tell you that, this is a very, very good question in COVID era. We have seen that people and cardiologists, interventional cardiologists particular, we have burned their fingers initially, and the data from Italy and US did show that a lot of cardiologists did lose their life because they got infected because of the COVID. And the reason is that, we also had, we are going to publish our experience also of COVID-related acute coronary syndrome and ECG changes. And there we see that the ECG changes could be because of the myocarditis. So COVID is very well known cause of myocarditis, and that causes, features mimicking the acute myocardial infarction. Only difference which we have seen that you don't see reciprocal changes in the opposite leads. So if the ST elevation is there in, anterior leads, you don't see ST depression in inferior leads and all. And when you do coronary angiogram, you don't find, obstructive coronary artery disease. There may be some plaque here and there, but that would not explain the kind of, ECG changes were there. So, and that had foxed lot many cardiologists that this patient could be ACS rather than COVID. So now we have become wiser with the experience. Worldwide data has shown. So myocarditis is the commonest cause which can cause this. But remember, you should not say that, it cannot cause obstructive coronary artery disease also. We had, so in our experience, more than 80% of the patients presented with classical, conventional obstructive coronary artery disease. The arteries were 100% occluded in respective areas. And now we have data that this is a pro-inflammatory situation where not only coronaries, but one can get clots in the heart arteries, but one can get into the brain arteries causing cerebral stroke. We have seen pulmonary embolism kind of feature, and even the renal complications are also thrombotic in nature and leading many patients to go on, dialysis. But since the inceptions of dexamethasone and, subcutaneous low molecular heparin and anticoagulation, these complications are becoming lesser and lesser. So the answer is that, we need to be really, very, very choosy in our selection of, going for primary PTCA. And I fully endorse what Dr. Praveen Chandra said, that don't jump the gun for primary PCI in these patients. You need to evaluate and try and go for pharmacological treatment initially till you have more answers about these patients.
Thank you very much.
Chandra, would you like to add something because you're busy with your patient?
Yeah, no problem. I'm so sorry. Actually, the answers which you gave for the management of acute MI is the way to go now. Although earlier we used to say different things, that for acute MI, primary angioplasty is the first thing to do. But in this present circumstances, this is what we have to take. And we have this now combination approach of pharmacoinvasive, I think is the best approach, and which is practical also today and also for India for a long time. So I think that's what I would like to say. And of course, giving dual antiplatelet therapy and all those things have to continue the same way as it was before.
Thank you very much, Praveen. There are two more questions. Both are addressed to Dr. Pancholia. The first question is, which is the best diuretic, Dr. Pancholia, from your point of view, and why?
Looking to the data and looking to the head-to-head comparison of the diuretics, chlorthalidone scores over the other diuretics because of its long duration of action. CV risk reduction is also reduced by 21% in the various trials compared to the hydrochlorothiazides. So in my opinion, chlorthalidone would be a better choice as compared to hydrochlorothiazide or other.
The second question is about the fixed dose combination. And the question is, in the fixed dose triple combination, which are the best 3 drugs you recommend choice we should consider?
So before Dr. Pancholia answers this question, I just want to say that I love three drug combination because patients are so happy taking it, and it's so easy to take, it's so effective. So I think this is what I wanted to say, because really my patients are very happy. In fact, they're happy with 4 drug combination also. So
is very
totally recommend that. So with this, I would like to take leave from all of you. And thank you very much, Dr. Chopra and Dr. Pancholia and Dr. Viveka and this IPCA company for the support. Thanks a lot.
Just a word, ladies and gentlemen, I must say from the core of my heart that all the speakers, Dr. Praveen Chandra, Dr. Viveka Kumar, and Dr. Pancholia has done a wonderful job. Their presentation were outstanding, full of meaning, and full of education, especially for practicing physicians, practicing cardiologists, cardiac surgeons, and everyone. And the message was very vivid with the data they've shown. And I think we learned a lot. I'm very happy. These are the 3 doyens of cardiology in their own way. They are very humble, full of humility, and I think the way they express, they have a huge, enormous plethora of experience of last 30 or 40 years. It's not easy to get them here at one platform. I'm very grateful to all the three of you. In last, I remember the words of Albert Einstein, who once said, learn from yesterday, live for today, and hope for tomorrow. Something better may come tomorrow. With these few words, I'll express my gratitude to all of you and each and every one of the speakers who participated in the interaction, and to all the people, all the members of IPCA family, especially Johnny, Avinash, and Sachin, and each and everyone from IPCA. And I'll hand over the mic to Johnny Edwin for a formal vote of thanks. Johnny, please.
So good evening, doctors. It's a great honor once again to have you all, and thanks a lot for the valuable timing for today evening, a very busy day on a Saturday. It was indeed a great contribution or academic feast, I would say, with regard to the treatment of hypertension, especially on uncontrolled hypertension, where IPCA per se is dedicated in towards the process of better control of this hypertension. So with this, heartfelt thanks to Dr. H.K. Chopra for his valuable organization thing which has provided us a good platform, and the panel and the speakers for today, Dr. Praveen Chandra, Dr. Viveka, Kumar, and Dr. Pancholia for the valuable time and an excellent contribution of academics. So thank you all, and thanks for your valuable support.
For all good programs, all credit goes to Dr. Chopra.
Yeah.
So nice.
All good programs.
Yeah.
It's exact 7 p.m. We started 5:30 and it's 7 p.m. We are exactly dot in time. Thank you very much once again, Viveka. You're looking very handsome and young.
Thank you very much.
Thank you.
Thank you. Thank you. See you later. Bye.
Okay.
Thank you very much.
Thank you.
Thank you, Dr.
Thank you. Thank you.
Thank you. Thank you.
God bless.